We are starting in 3, 2, 1. Please start, sir. We are live.
Sana ma'am, you can start the proceedings.
Good evening, everyone. A very warm welcome to Elite Meetings. So we have basically doctors from the heart of India on various sessions. We have 4 sessions total today. And Dr. Sameer Purun, this is the agenda. Can you go to the next slide, please? So this is the agenda for today, but we're supposed to be starting with Dr. Sameer, but unfortunately he cannot join today. So we'll start with next speaker as Dr. Vaibhav Chaudhary. So he'll be speaking on newer targets in lung cancer space, mainly the molecular targets, which is one of his area of interest. So he'll speak on that. Over to you, sir.
Yeah, good evening, everyone. Myself, Dr. Vaibhav Chaudhary. I just wanted to share my screen. Yeah, that's it. Yeah, myself, Dr. Vaibhav Chaudhary. I am a practicing medical oncologist in Wokhart Hospital, Nagpur, and I expertise in mostly solid tumors. Lung is something which is very close to my heart. Actually, everyone's lung is very close to their hearts. So the newer targets in lung cancer space, actually something which has been very, very exciting in whole oncology space is lung cancer. And it has come a long way in past 20-25 years. Courtesy chemotherapy, targeted therapy, immunotherapy, and the ADCs, antibody drug conjugates. These are the new kids on the block, and on, newer things are coming on. So my job today is actually a very simple one. I just have to discuss about 3 targets, which obviously I was not able to pronounce properly. One is CD73, one is NKG2A, and one is TROP2. These 3 markers actually are very, very important for filling the gaps in today's continuum of treatment of lung cancers in various stages as such. Like we are very, very happy, and very happily we tell people that we have got target therapies and we have got TKIs and it can take care of your cancer for years together. Yeah, true. But there comes a time then even after the TKIs, patients have progressed, and then honestly speaking, there is patient is still having a good performance status and he doesn't have any standard line of therapy left. So it is left at the mercy of treating medical oncologist. Whatever his experience based treatment is there, he has to give. Or then the best thing which is possible is enrollment in a clinical trials of these new evolving drugs. So gradually we will start deciphering these 3 targets, and these 3 are actually very, very important. In the recent ESMO 2021, very good data were presented targeting.
Sir, sorry for intervening. Your slides are not moving.
Yeah. Now it is?
Yes. Perfect.
Yeah. So antibody drug conjugates. First of all, I'm starting with TROP2. Now TROP2 is a tropoblastic antigen 2. It is also called as epithelial glycoprotein 1. It is actually a very good target which can be actually exploited for giving targeted therapy, because it is a transmembrane protein with extracellular domain, and it is significantly overexpressed in a variety of cancers, not only lung cancers, but a lot of tumors, especially lung cancers, all 3 varieties, squamous, adeno, as well as in small cells. So it has been studied extensively. Overexpression of TROP2 is also very common in metastatic breast cancer as well. It has been said that its overexpression is associated with poor survival rates in patients. So all of us remember this molecule, sacituzumab zoviotecan. This actually works on the same target, TROP2, but the earlier trials did include a few patients of lung as well, but they found a very good signal in triple negative breast cancer. And as it is an ADC, so in triple negative breast cancer, post 2 lines of chemotherapy, it has just recently achieved 1.5 years back the FDA approval for treatment. On similar lines, the drug which is much more active in lung cancer, that is datopotamab deruxtecan, dato-DXd we can call it. So this is the molecular structure and this is the mechanism of action of this ADC. It is just like the first ADC which we came across was in breast cancer, that was TDM1. And it is very simplistically written here that, yeah, it does bind to that transmembrane TROP2 and get internalized into the cancer cells. Obviously, they are overexpressed on cancer cells. It goes inside the cancer cells and then it contains an active chemotherapy moiety, that is DNA topoisomerase 1 inhibitor, and it causes DNA damage and apoptosis. It doesn't only stop there. Actually, it permeates and penetrates to the neighboring cells and it releases the payload there as well. This is because of that cleavable linker. So these are actually more advanced molecules, ADCs, than the first generation ADCs which came in. And that is the reason that these are having a very profound effect. It takes care of tumor heterogeneity. It takes care of resistant cells as well. So that's why it leads to a marked tumor regression. This is about the mechanism of action. So not actually it is this molecule is being studied upon, and we just received recent updates from this phase 1 global study of Tropion pan tumor 01. Actually, it is a study which is devised out of necessity, and it is an ongoing multi-center open label dose expansion study of dato-DXd in solid tumors, almost 210 patients, which actually included some lung patients as well, lung cancer patients. So the objectives were assessing safety, pharmacokinetics, anti-tumor activities, and the patient who have actually progressed after standard treatment and had no standard treatment available with measurable disease. Stable and treated brain mets were also permitted. Patients were not selected based on TROP2 expression or age. So these are the results in short, that 34 patients had advanced metastatic NSCLCs with actionable genetic mutations were taken in these studies. Out of these 34 patients, 8 patients were maintained at a dose level of 4 mg per kg, 10 patients at 6 mg per kg, and 16 patients at 8 mg per kg. The protocol of phase 1 study, decent number of patients were there. 82% of the patient had received more than 3 lines of prior regimens. As we know, lung cancer as well, and also these biomarker positive lung cancers do receive TKIs. 85% had prior TKI exposures, and almost 69% of EGFR had prior received osimertinib. So these are those patients who had progressed after years of TKIs. Median duration here was 13 months, and this was actually very, very amazing and surprising to many people that the confirmed ORR was almost 35%. It's a big number in such a refractory setting, and median duration of response was 9.5 months. Most common any grade adverse event was nausea, 62%, stomatitis, hematological toxicities were infrequent. One alarming signal was there that one patient actually had a grade 5, I mean, patient died with interstitial lung disease, and he was at the top dose level of 8 mg per kg. So now people are titrating the dose to 6 mg per kg, and then based on these results, we can draw some conclusions. It's actually very early, phase 1 studies are like that, but anti-tumor activity and safety in advanced metastatic NSCLC patients with AGAs are encouraging. Actually, they don't have a current standard line of treatment. Ongoing phase 2 Tropion 05 lung trial actually is assessing the lower dose levels at 6 mg per kg in such patients, and it is an ongoing study. Time will answer whether this molecule is successful or not. So nonetheless, interesting data. Coming to our next topic, that is anti-CD73 and anti-NKG2A immunotherapy combinations. This is a COAST trial. This was again presented in ESMO this year, and this is an open label phase 2 platform durvalumab alone in combination with novel agents in patients with locally advanced unresectable stage 3 NSCLC. As we all know that Pacific 3 has actually established a new standard of care in stage 3 lung cancers. But what happens after that? Not everyone is cured with durvalumab. as we all know that 42.9% remain alive and 33.1% rely at the and PFS of 5 years. Additional immunomodulation is required because obviously, though durvalumab is very active and has added a lot of years to life of such patients, but still at the end of 5 years, almost half the population is gone. So to add on to that, this trial actually was initiated and newer drugs were tried in combination with the standard of care. So this is the rationale. Rationale is very interesting that after CTRT, which is the standard of care for unresectable stage 3 NSCLC, radiotherapy induces expression of CD73 and NKG2A ligand, which inhibit anti-tumor immune responses. So oleclumab, which inhibits CD73 to reduce extracellular adenosine production and thereby promoting anti-tumor immunity. The patient actually it has shown some good results in phase 1 study of advanced EGFR mutated lung cancers. So this is a rationale. Second is monalizumab blocks NKG2A to reduce inhibition of NK and CD8 positive cells, and it did show a positive signal in a study of head and neck cancers. So combination of radiotherapy and these two molecules is also taking place, and that also is having good results in preclinical models. So this is the COAST-2 study, a very simple design where they had actually randomized in 1:1:1. One is the standard of care durvalumab arm. In second arm, they have added oleclumab. And in third arm, they have added monalizumab with a primary endpoint of ORR by investigation assessment. Secondary endpoints of safety, DOR, DCR, PFS, OS, PK, and immunogenicity. So they wanted to actually have 60 patients in per arm. As between July 19 to July 20, they enrolled some 186 patients and they achieved their target of enrollment. In May 17, 2021, all patients had a minimum of 10 months potential follow-up. So this data was presented where, as you can see, the baseline characteristics are almost similar. They had almost equal percentage of squamous as well as non-squamous histology. They had more patients of they had actually a lot of PDL1 status was unknown, as you can see, but that was there in all the groups. So the groups were equally matched. Cisplatin versus carboplatin was also there, which actually in subset analysis it will come up. And the patient which with anti-tumor activity by investigator assessment was there in ITT population, and confirmed ORR was actually better in the combination groups, in both the combination groups of D plus O as well as D plus M were better as compared to durvalumab numerically. Similar things were observed in form of DCR at 16 weeks and the median DOR as well. These are the PFS curves, and here, as you can see, that there is a marked PFS improvement with both the combinations actually, and as compared to the baseline of durvalumab. At the 10 months, 39% of the patient of durvalumab were disease-free compared to 64 and 72%. So this is a subset analysis, as you can see across the board. Almost all the categories of the patients, the combinations were better individually as compared to durvalumab. When it comes to the safety, as you can see, the class effect of durvalumab and the safety profile, we are all very well versed with it. That was seen in every in the combination group as well, and there were no alarming toxicities. There were no new toxicities which are attributable to these two drugs when given with durvalumab. We are very well versed with managing the immunotherapy IO toxicities, and as you can see, it was all very predictable and manageable. So as you can see, there was no alarming toxicity, as I told in the last molecule, that ADC, which had interstitial lung disease and patient died. Here in this study, there was no alarming toxicities like that. So what it leads to is actually it is very encouraging study, which shows that by adding these two drugs with durvalumab, either of them actually had a better response and actually both the combination numerically increased ORR and significantly improved PFS over durvalumab. PFS benefit was with both combination was observed across subgroups, across the PDL1 status as well. So this is one more concern, that even progress after this is not pertaining to this setting, but in stage 4 setting, patients do progress on PDL1 inhibitors, and then these drugs may actually give a ray of hope to such patients. So these data actually support further evaluation of these combinations in registration intent studies. That's all. I think I don't have more data on these newer drugs, so I would like to take a leave, and thank you. Thanks a lot.
Thank you so much, sir, for that talk. We'll move on to the next speaker. So, next speaker is Dr. Sameer Srirangwar. He's a consultant medical oncologist in NCI Nagpur. So, what he'll be sharing is a very interesting case that he came across. He precisely used precision medicine to treat that case, and the patient is still doing good. So, over to you, sir, for the talk.
Am I audible?
Yes, sir, you're audible.
You will share the slides?
You want me to share? Yeah, just give me one.
You can share, I can take over from there.
Yeah. Share it.
Can I take over? Is there an option of taking over?
Tech support, is there an option that
Yes,
sir can move this?
You can, I think, just keep the previous slide. Previous slide, first slide. So good afternoon, good evening, all of you. So I would thank first AstraZeneca for arranging such a wonderful meeting of precision oncology in lung cancer. So we all aware that lung cancer is one of the best example of any solid tumor where the precision oncology has really helped our patient in improving their outcome. So definitely it has set example for other tumors where we expect that we should have such target therapies available so that further outcome of other solid tumors can also be improved. So my job here is today to share such example of lung cancer patient where how precision medicine has helped my patient to improve their long-term outcome. Next slide. I'm sure that this my case is so interesting that it will definitely set up a stage for our panel discussion where we can definitely discuss further issues here. So my case, I will start with the case. So my patient presented with history of, actually he's a 46-year-old gentleman with no comorbidities, no addiction. He was ECOG PS1 at the time of presentation. Next slide. So he presented to me in September 2018 with a chief complaint of backache and hip pain for 2-month duration. Then he had a history of change in voice since 15 days. And he had one episode of seizure just a day before he came to us. Next slide. So he was investigated at our center. We did a PET CT, which showed a primary neoplastic lung mass with bone, lymph node, lung, and pleural metastasis. He had a history of seizures. So we did a MRI brain, which showed multiple brain metastasis. So we did a lung biopsy, which was suggestive adenocarcinoma. So it was 2018. That time we did only EGFR cross. So his EGFR exon 19 deletion was positive. Alcan ROS was negative. PDL1 was less than 1%. So our final diagnosis was stage 4 lung adenocarcinoma, EGFR exon 19 deletion positive. Next slide. So this data we all are aware what are the options for EGFR positive lung cancer patient metastatic. So we can use either first generation EGFR TKI. So nowadays we rarely use it alone. We generally combine with other therapies nowadays. That is gefitinib or erlotinib. We have second generation EGFR TKI, that is afatinib, dacomitinib, and we have now third generation osimertinib also in first line, which is now a standard of care. Even we have combination of erlotinib, ramucirumab, erlotinib, bevacizumab, and even EGFR TKI plus chemotherapy data from TMHP we have, and we are routinely using this all of these agents. Next slide. So at that time we started this patient on first line osimertinib. He had very good response to osimertinib initially. He almost had a regression of most of his lesion. He did, but he did well only 10 months actually. So he actually not had a long response on osimertinib, and only after 10 months he progressed. Next slide. So we always discuss in various meetings what should be done after osimertinib. So means there is definitely no clear-cut answer to that. Means most of the clinicians use only chemotherapy. So even in Flora trial, we can see here in out of 279 patients received osimertinib, almost 133 patients received second-line therapy. Out of that, most of the patients received only chemotherapy. So some people say that ABCP, that is the atezolizumab, paclitaxel, carboplatin, is the best regimen to be offered to this patient post-progression osimertinib. But very few people can afford that. Is a very costly regimen. So we generally end up giving only PEM carbo, which is the routine chemotherapy. So even in, if you see this data of comparator arm, that is EGFR TKI, here out of 277 patients, 180 patients received second line therapy, and out of that only 47% of the patient received osimertinib. So that means that if the patient don't get osimertinib in the first line, there is a very less chance that they will get second line osimertinib. If the patient has received chemotherapy in the osimertinib in the first line, most of the patient received only chemotherapy. Next slide. So so my patient also received PEM carbo as a second line chemotherapy. He responded well to PEM carbo, and then he received maintenance pemetrexed, and actually did very well on maintenance pemetrexed for almost 2 years. He received almost 29 cycles of maintenance pemetrexed. After that, he developed new onset liver metastasis, that is progressive disease. Next slide. So when he progressed on PEM carbo, I thought his disease biology is really very good. So he actually not responded to PEM osimertinib, which was expected to have DFS of around, or PFS of around 20 months. He progressed in only 10 months there, but he responded very well to PEM carbo. So I thought, let's do an NGS again and just see what is happening here. So I did a biopsy from the liver lesion this time, and that was a new lesion, and I did NGS this time. So actually, initial progression was around in 2019. That time, NGS we were not doing that routinely, but this time it was 2021 May. So we did a NGS here. So surprisingly, what I found, there was a EML ALK4 fusion here, mutation fusion positive along with the mutation in EP100 gene. So I tried to find out what is happening here. I tried to find out some literature here. Is there any data for EML ALK4 fusion as a mechanism of resistance to osimertinib, or any data on this after progression on osimertinib? So next slide. So I found a good, interesting case report from our Indian hospital only, that is Rajiv Gandhi Cancer Institute by Dr. Ullas Batra. So he has reported one case of EML ALK4 fusion as a resistant mechanism to osimertinib, and he treated this patient with osimertinib and alectinib combination. So basically, what happened here is that in this case report, what he have reported that his patient, when progressed on osimertinib first line, repeat NGS was showing EML ALK4 fusion along with original EGFR mutation positive. So what was different in my patient was that there was no EGFR mutation positive, but only EML ALK4 fusion. So what I did, next slide. So I thought it may be because of tumor heterogeneity. So that's why what I did, I started him on alectinib in May 2021, but I did a liquid biopsy also to find out whether there is a EGFR fusion, EGFR mutation still present in one of the clone, which is not picked up in biopsy, but maybe picked up in liquid biopsy. So interestingly, I got the EGFR mutation exon 90 deletion positive liquid biopsy, which was present in the baseline biopsy. So I did a lot of discussion here. I presented in our actually molecular tumor board also. So what we decided to add actually EGFR TKI also. So that time the patient was saying he will not afford osimertinib because alectinib was already costly for him. So we added gefetinib. Next slide. So after this combination of gefetinib plus alectinib combination, response CT scan at 3 months was suggested a partial response. And after 6 months, he had a very good ongoing response to therapy and is also symptomatically much better. So clearly, this clearly shows that sequential biopsies may definitely open a potential strategy for new novel treatments, and definitely NGS and precision oncology can help us to further improve the outcome of the patient, which may be definitely not written in any clinical guidelines or any book, but definitely we can always get a new mutation, something different post progression on any targeted therapies, and that can definitely open a way for next line targeted therapies. And definitely, so as the data is evolving for osimertinib resistance or any means like aceritinib resistance or lorlatinib resistance, we can definitely explore this data on resistance mechanism, and depending upon the whatever the resistance patient has developed, we can start the next line targeted therapy, which can even further improve the long-term outcome of this patient. So I will end here. Thank you.
Thank you so much, sir. So any questions or any comments from the team for, you can unmute yourself and ask questions or any comment from your side, from the audience.
So I think we
Okay,
can
sir,
move
yeah.
forward and we can
Yeah,
discuss in our panel discussion also.
Just understood. Okay, sir, sure, no problem. So we'll move on to our next speaker, Dr. Nikhil Pandey. He'll be presenting on how, so we all know immunotherapy has taken a good place in advanced lung cancer. So how is it changing the early lung cancer space? That is what Dr. Nikhil Pandey will be talking about. So if you can take over.
Yes, ma'am. Can you share my slides?
Yeah, sure. Takes a bit, please share sourcely.
So good evening, everybody. Thank you for the organizers. I'll just talk about how is immunotherapy changing the early lung cancer space. Next slide. We all know that newer treatment options have chances of improving survival in lung cancer. So basically, what this NEGM paper, which was in 2021, shows that the incidence, although is decreasing, there is incidence has decreased annually approximately 3.1%, but the incidence-based mortality also is reducing in lung cancer. So basically, I want to say that we are moving forward in lung cancer. Next slide. So this is something which we all know, that immune checkpoint inhibitors have shown improvement in advanced NSCLC, and the 5-year OS has improved, as especially in those with PD-L1 more than 50%. Next slide. And there are addition of locally advanced NSCLC also, where durvalumab has improved the PFS rate from 42 to 43% approx, from 33%. So immunotherapy is there in advanced NSCLC if you take stage 3 as well as stage 4. Next slide. But if you look at the early stage lung cancer treatment options, you would consider either surgery plus chemotherapy, chemoradiation in certain cases, surgery with targeted therapy, chemotherapy plus or minus immunotherapy, surgery and immunotherapy. So the last two are the questionable things which we will address. The other points we already know. Next slide. So there is always, in any solid tumor malignancy, I think there's a doubt whether adjuvant versus neoadjuvant. Adjuvant allows the fastest time to surgery, no risk of pre-surgery complications from systemic therapy, enables longer treatment duration for systemic control, and more flexible timing post-surgery, provides more recovery time for patients. Whereas neoadjuvant approach provides earliest opportunity to eradicate micrometastatic disease, increase treatment initiation rate and compliance. Pathological response provides early indicator of response to therapy and can guide future treatment decisions, and can potentially eliminate live tumor cells released into circulation during surgery. Right? Why do we need immunotherapy in early lung cancer? So chemotherapy improves survival by only 5 to 10%. Relapse rate is very high with only surgery, and many patients do not receive adjuvant therapy. So approximately 52% did not receive adjuvant chemotherapy in a retrospective analysis of 831 patients. Next slide. So adjuvant treatment stage 1A, I think we all agree on observation. 1B, 2A, medical oncology consult to discuss observation versus chemotherapy. I think we'll err on the side of chemotherapy. Stage 2B, chemotherapy, yes. 3A, 3B, chemotherapy or sequential chemotherapy and radiation in N2. Next slide. We all know there's adjuvant chemotherapy in early lung cancer. There is LACE trial, and we know that adjuvant chemotherapy has provided the benefit, although the benefit increases as the stage advances. Next slide. But what about immunotherapy in lung cancer? So major progress with immune checkpoint inhibitors in metastatic as well as consolidation stage 3 NSCLC are encouraging to study them in early lung cancer. Preclinical evidence suggests that neoadjuvant ICI should be more efficient than adjuvant therapy. It is thus very important to see how ICIs in clinical trial will help improve the cure rates in early lung cancer. Next slide. What will be the benefits of adjuvant immunotherapy? The primary goal of adjuvant therapy is to treat micrometastatic disease, prevent recurrence, and allow for the primary tumor, which is the source of micrometastatic disease, to be removed as early as possible. Immunotherapy is relatively well tolerated as compared to cisplatin-based chemotherapy and offers a potential for a durable, long-lasting anti-tumor response. Next slide. So what are the trials which showed positive response in adjuvant settings? There is the IMpower 010, which was the primary result in phase 3 global study of atezolizumab versus best supportive care after adjuvant chemotherapy in resected stage 1B to 3A NSCLC. Next slide. So the study design was simple. After offering cisplatin and pemetrexed or gemcitabine or docetaxel or vinorelbine 1 to 4 cycles, 1:1 atezolizumab versus best supportive care, and survival was the follow-up. Next slide. So what it showed is, the DFS in PDL1 greater than 1% patient stage 2 to 3A population. If you look at the median DFS, it was not reached in atezolizumab arm versus 35.3 man. Stratified hazard rate of 0.66% and a p-value of 0.004. So definitely, even at 2 time frames, that is 24 months and 36 months, the atezolizumab arm did better as compared to best supportive care. Next slide. And in all randomized patients, with irrespective of the PDL1 status, it was 42.3 versus 35.3, which was still good enough, with a hazard ratio of 0.79 and a p-value of 0.02. Next slide. If you look at the subgroup analysis, and if you look at the PDL1 status, if you have more than 50%, definitely your hazard rate is much better. If more than 1%, it is at 0.66, and less than 1% is the one where the benefits are actually not seen. Next slide. Let's have a look at the ongoing trials. So there are multiple trials. IMpower 010, we have already seen the completed accurate. There is an anvil trial which is also completed accurate. It is adjuvant chemotherapy. The intervention arm is CT, NR, RT, again, which was permitted here. Sequential nivolumab versus observation for pembrolizumab. There's the PEARLS trial. There is BR31, which is for sequential durvalumab versus placebo, and the Alchemist trials, which is concurrent pembrolizumab followed by pembrolizumab versus sequential pembrolizumab versus observation. Next slide. What is the use of neoadjuvant chemotherapy? Preoperative chemotherapy for NSCLC systemic review is a 10% reduction in distant metastasis at 5 years, 13% relative risk reduction of death, 5% improvement in 5-year OS, and a hazard ratio of 0.87. Next slide. And why immunotherapy will be beneficial in the neoadjuvant setting? Immunotherapy is comparatively very less toxic than platinum doublet chemotherapy, more appropriate for patients with contraindications to chemotherapy, Neoadjuvant chemoimmunotherapy has the benefit of higher rates of MPR and inducing response in patients who may not benefit from ICI monotherapy. And it has the potential to augment downstaging of nodal disease, particularly in patients with stage 3 disease, which in turn may improve the resection rates. Next slide. But can we think of immunotherapy versus chemoimmunotherapy? There are trials which are thinking of adding nivolumab, atezolizumab, and nivo or EP combination as well, which are going on, but we need to have a data on that. Next slide. And which are the trials which showed positive response in neoadjuvant settings? There is nivolumab plus platinum doublet chemotherapy versus chemotherapy as neoadjuvant treatment for resectable 1B to 3A NSCLC. This is the Checkmate 816 trial. Next slide. The study design was simple, adding nivolumab at 360 mg 3 weekly plus chemo versus chemo alone, followed by radiological restaging and surgery within 6 weeks post-treatment, and optional adjuvant chemo with or without RT. Next slide. If you look at the response of tumor to neoadjuvant nivolumab, there is, in this case, 100% pathological regression of the large primary lung tumor with a 35% shrinkage in tumor size. And post-treatment specimen, there was 90% tumor regression in the patient 1 and patient 5 respectively. So there was an appreciable tumor response. Next slide. And Checkmate, if you look at the PAT-CR rates, it is the intention to treat population. There is a nivolumab plus chemotherapy arm had a significant 24% PAT-CR rate with a difference of almost 22% as compared to chemotherapy alone. And in patients with resection, it was 30% versus 3%. And primary tumor only when assessed, it was 25% versus 2.8%. Next slide. If you look at the overall response rate and radiological downstaging, the overall response rate was 96, which is sort of unheard of. In 54% of the patients there was a ORR, and in chemotherapy alone it was 37%. So yes, there was a significant patients which had radiological downstaging. Next slide. If you look at the ongoing trials, there are a lot of them. Checkmate 816, as we already seen, has completed accurate. There's the Keynote 671, which is pembrolizumab or placebo, 4 cycles of Gemcis or cis with pemetrexed. IMpower 30, 4 cycles of carbo pemetrexed, carbo nab-paclitaxel or cis pemetrexed or cisgem with atezol versus addition of atezolizumab or placebo. There's the same going on with durvalumab in the AGN study. And Checkmate 77 T is the one which added only nivolumab or placebo. Next slide. We just put a short time on the AGN study. It was resectable stage 2A to 3B NSCLC. All comers were stratified into 1:1 randomization into durvalumab 1500 mg plus platinum doublet 3 weekly into 4 cycles versus placebo plus platinum doublet followed by surgery, followed by durvalumab maintenance for 12 cycles more versus placebo. Next slide. And how do you monitor or prevent recurrences in resected patients? Identifying and treating MRD can prevent recurrences. So in the Abosh et al. In the Tracer X study, 24 NSCLC patients followed longitudinally after resection, 14 identified as MRD positive, and 93% of which experienced disease recurrence. 10 identified as MRD negative, only 10% experienced recurrence. In the Chaudhary et al. Study in the same year, there were 37 cancer patients receiving curative intent therapy, 17 identified as MRD negative, out of which only 1 developed recurrence, versus 20 out of 20 who were MRD positive developed recurrence. So there is something like an MRD monitoring which might be possible in NSCLC as well. Next slide. And these are the patients that high risk who can, to avoid recurrence, we can consider MRD negative patients of no further treatment versus MRD positive patients of additional earlier treatment, that is either IO or chemotherapy combined. Probably this will help in improving the long-term outcomes. Next slide. So what are the trials which are evaluating IO in MRD positive patient? There is a Mermaid trial, which is a double-blind placebo-controlled study of adjuvant durvalumab plus platinum-based chemotherapy in completely resected stage 2 or 3 NSCLC. So post surgical plasma sample at week 3 or 4, assess MRD status, 1:1 randomization between durvalumab plus standard of choice chemotherapy versus standard of care chemotherapy plus placebo. Next slide. There is also the Mermaid 2, which is a phase 3 blinded trial of durvalumab versus placebo in circulating DNA positive stage 2-3 NSC following curative intent therapy, almost with a similar design. Next slide. So in conclude, immunotherapy has become a part of standard of care treatment for patients with advanced or locally advanced unresectable NSCLC. Numerous studies are underway to determine the efficacy of ICI therapy treatment of early stage NSCLC, and ICI given in the neoadjuvant settings have the potential to induce good responses, improve resectability, and diminish rates of clinical metastasis. As well, while adjuvant immunotherapy will increase disease-free and overall survival.
Thank you, sir. Thank you so much for that talk. We'll move on to the next talk. It's by Dr. Akash Tiwari. He is a consultant medical oncologist at Shalby Hospital, Indore. He'll be talking on the screening perspectives of lung cancer. Over to you, sir.
Good evening, everyone. I hope I'm audible. The
Yes,
slides
you're
are
audible.
visible. Sure.
Yes, sir.
So we today, in the era where in most conferences we discuss adjuvant targeted medicine, immunotherapy, or in our academic sessions where we discuss who would require adjuvant chemotherapy, radiation, not require therapy, the topic is interesting and it concerns primarily the community. So it is in this screening perspectives in lung cancer, if it is the prime time currently or not. So why this talk of screening in lung cancer arises? And it comes from this startling data that only 14% of the patients that we see in our practice come with localized diseases. And lung cancer, despite of its reducing incidence, still continues to be one of the tumors with highest mortality rates, and hence we need to diagnose these patients at an earlier stage and treat them accordingly. So this has been an unmet need in oncology for a significantly long period of time. We see that over past few decades, the incidence in men has reduced startlingly, almost by 3.1%. Also has the mortality reduced, but it still remains, the age-adjusted mortality remains of around 20-25% in men. In women, even this decreased in incidence of lung cancer has not been too stark, though of course with improved treatments, the mortality has reduced. So we have a disease whose incidence is reducing, but the outcomes remain dismal. A disease which is primarily picked up in a higher stage disease. So we see in certain series that almost 65% of the patients are diagnosed in stage 4, or almost 1/3 of the patients are locally advanced, and only around 1% of the patients are diagnosed in early stage tumors. On the contrary, once we diagnose them in stage 1A, stage 2, the survivals ranges from between 60 to 92%, which is as good as the survivals in breast cancer that we get. So what do we want? We want to diagnose these patients earlier. That is, we want a stage migration for our patients. There are two main strategies that can be used for this. One is screening, which is of course the mainstay of the strategy. Other is the incidental pulmonary nodule strategy. So finding these incidentally found nodules and following them up to diagnose an early disease or to label them as benign. So in screening, there have been two main trials that have come up. One was the NLST trial, other was the Nelson trial. In both these trials, they had found out these high-risk populations, people with high smoking indices, people who had who were men who continued to smoke. And in this population, when we had done a low-dose CT and compared it to chest X-ray, we had seen that the mortality or the relative risk of mortality has come down by around 20%. So in the NLST trial, this criteria was based on the size, whereas in the Nelson trial, this was based on the volume of the disease. The second question in this screening comes out to be, though we know that there's significant data of screening the high-risk population. And as an individual, in individual internal medicine practice, we must offer it to our patients. Is a mass population-based screening possible in India? And there are a lot of limitations that come to us. So first is infrastructure, providing so many CT scan machines at every nook and corner of the country. The cost of such an intervention, depending who bears it, the government or the patients. Then the criteria of high risk is based on smoking index, but a lot of various forms of tobacco are calculated are consumed in our country. So what would be the equivalence? And then there are the routine issues that come with screening. So the motivation, chances of overdiagnosis, and a peculiar issue in our country that the chest infection and pulmonary tuberculosis rates are very common. So there'll be a lot of confusion in terms of what is a granuloma, what is a suspicious nodule. So one strategy is screening the high risk. The other strategy is incidentally detected pulmonary nodules and their follow-up. So we see in this beautiful graph that almost in a walk-in clinic where we are seeing only lung nodules, around 62%. So almost 2/3 of the patients that we see are actually incidentally diagnosed pulmonary nodules. Of course, not in our scenario, but a lot of Western countries. And there are only 15% that are symptomatic, 13% that are screening detected. So our focus on these incidentally detected pulmonary nodules should be stark. If we find these patients which are incidentally detected pulmonary nodules and we follow up them thoroughly, we see a stage migration. So in symptomatic presentation, almost 60-70% of the patients will be stage 3, stage 4. While if there's an incidental nodule program, the rate of stage 1 detection is increased to almost 54%. And this is something that can be implied in our practice, especially when we have seen that a lot of CT scans that we have done for COVID, they reported certain nodules. And some of these patients, when we have followed up, they have turned out to be CA lung in subsequent times. So a lot of oncologists have similar stories. So how do we otherwise move up in the lung cancer ladder? So where we focus currently as oncologists is optimal systemic therapy, correct diagnosis, surgical resection, radiation, what form of treatment we must select. There are two other points of ladder. The most important is tobacco control. If we are not controlling tobacco, the next step is high-risk population low-dose CT. We feel that the missing link here is the management of the incidental pulmonary nodule. So a CT that is done for an unrelated reason, a thoracic CT for a CT angio, a screening CT before a surgery in these things. If we detect an incidental nodule, depending upon its size, the age of the patient and the risk of the cancer, we must follow these patients regularly. So that is one important message that we must take from here. There are two main data of low dose CT. One is of 30 pack years versus those in more than 50 years and 20 pack years. You know, as we reduce the threshold of our screening, the chances of picking up cancers increases, but so does the chances of picking up false positives. So how should we practice? Till such time that there is a universal lung screening protocol in India, which is unlikely to be given our current health scenario and lacunae at far more important places, we must offer low-dose CT to our high-risk population who come to our clinic and do an IPM detection as complementary strategy. With this, we require actually a collaboration with the pulmonary medicine team and the medicine specialists who get their CT done, and we have to educate them for follow-up. One important strategy that can come handy to us is artificial intelligence. So currently we see that there's a lot of push, a lot of publications coming in this sphere, a modality that will help our radiologists to diagnose doubtful IPNs and to follow them subsequently. A lot of time we feel that the time of AIs have not come, and probably we, without the help of technology, will keep seeing our patients as radiologists and medical oncologists. But remember, pre-2020 March, a lot of us also did not believe that we'll be doing these online meetings regularly and not meeting up over a drink in evening to discuss oncology. And we feel probably in the same spate, probably AIs would also change how we diagnose IPNs and follow them up. So how can we as oncologists support in early diagnosis of lung cancer? One is that we can create this awareness in general physicians and public that lung cancer as a disease, to diagnose them early, so that a lot of patients that we see who come as treated as tuberculosis get their biopsies done. We have to remove the stigma associated with the disease so that people come up with it. We have to collaborate with our physicians, pulmonologists, so that if they detect incidental nodules, we should do a thorough follow-up of it according to the existing guidelines. And we must show our community that lung cancer patients, if diagnosed early, survive. Even in metastatic disease, they have good outcomes, so that people continue to have a positive outlook towards it. So of this question that is it prime time for lung cancer screening, we feel that lung cancer still, even with decreasing incidence, is a disease with high mortality. And if we do not intervene now, when would we do? And therefore, on individual case-to-case basis, as practice, we must offer low-dose CTs, and we must help our colleagues to or educate them how to follow up these incidental pulmonary nodules, such that we are able to diagnose lung cancers early. Thank you.
Thank you so much, sir, for that talk. We'll moving on to panel discussion on managing early lung cancer patients, which will be moderated by Dr. Tejinder Singh. And we have on panel Dr. Praveen Paliwal, Dr. Amol Dongre, and Dr. Sameer Srirangwar. Oh, so if you can take over.
I think I'm audible right now. No?
Yes, sir. Yes, sir. Audible.
So Akash is also there in the board?
Yes, sir.
Yes, sir, I'm there.
So Akash is there, Dr. Praveen is there, Nikhil and Dr. Sunit is there, right?
Sunit
Yes.
Dr. Sunit is there?
No, sir. Dr. Amol and Dr. Sameer Srirangwar, sir.
So you have right now Dr. Akash is there
Yes, sir.
and Dr. Amol is there
Sir.
and
Yeah.
Dr.
Dr.
Praveen.
Yes, sir.
So only 3 people are there.
And Dr. Sameer, sir.
Okay, Samir is there. All the
Yes, sir.
speakers are there. Okay.
Yes, sir.
So I need not ask any question. Everyone has already answered it, right? So Amol, Akash gave a very vibrant talk on the role of what you call as looking at the disease, that there's a big role of cancer screening, right? And
Yeah.
he also made a comment that after the recent COVID thing has come, you are seeing an increase in the lung cancer patients and you are getting more number of patients. How much is it good in your practice?
So, sir,
Pardon?
You are seeing more number of patients of lung cancer post-COVID.
Yeah.
You are getting more patients?
Sir,
Yeah.
what,
Basically, it's not about
sir,
getting.
sorry to cut you short.
But
No, Akash, I'm just telling that the number of CT scans have increased. So we are seeing little bit slightly increase in the incidence of lung cancer in your
we are
practice.
seeing them a little earlier, sir. So that's
Earlier.
what I meant.
So you are getting now more early cases.
So,
As
sir,
compared to COVID.
in my as in my practice, we remember that say till 2019-20, we had only one surgery for lung cancer in our center. In this past, we are a low volume center at a private center. We've had almost 4 patients who have been operated for CA lung. What I meant is that because there were so many CTs happening, there are certain patients who were picked up early at small nodule.
No,
Not only
I'm
for
not
lung
saying,
cancer, but
I
a
am
lot
not
of
saying
other.
anything. Reason is that I have not seen an increase in the early lung cancer. That's the reason I'm
Okay.
asking.
Okay.
So, Amol, what is your take on this early lung cancer in the last 1.5 years in your practice because of so much of CT is going on?
But yeah, so as rightly said by Dr. Akash also, it's not like we are seeing increased number of lung cancers, but yes, since because of this COVID, lot many patients underwent CT scan, and now we got at least I mean, if previously it is like 1 patient, now we are getting 3 to 4 patients of lung cancer. I won't say we are getting much early stages, but yes, the incidence of lung cancer has definitely increased after this COVID PET.
Early lung cancer.
Yeah.
So, Dr. Praveen and Dr. Sameer, what is your take on your practice because of COVID thing? You are seeing more number of early lung cancer now?
Not really, sir. So
yeah. Okay, fine. And what about Dr. Sameer? Sameer, I think is working in NCI, no? Sameer is there or he has left?
He's working on in NCI.
NCI. Okay, fine. So anyway, I think this is a point which everyone has highlighted looking at the overall survival outcome. And we tend to see more number of patients in stage 4 only, getting, even though we have so many meetings of stage 3, but finding too much of stage 3 is near impossible. We tend to see more of stage 4. Stage 1 and 2 do come, but in the last 1 year, I'll say 1 patient only had come for adjuvant therapy. So I am not seeing so much, but it depends upon center to center. It depends upon how well known is your basically the surgeon from the thoracic side. If you have the high volume, then they get, like our places like Asia Cancer Institute in the private setting, there are more number of patients who are basically there you get more number of lung cancer patients. So, but yes, we talk about overall survival with the stage, less the stage, more the survival, more the stage, less chance for the survival. So that is what I was asking in the thing. Now, Dr. Akash, you are working in a place where I think you have a good number of patients on lung cancer. Now, looking at this stage 1, 2, 3, I'm not talking about 4. So what is the percentage in your clinical practice?
So, sir, stage 1, 2, we rarely see. We see almost 10-15% of our population would be stage 2. 1 occasionally. So, as I told you, an operated lung cancer, we remember seeing 1 in the practice. In recent times, we have seen more. Stage 3, not particularly, but stage 3 in general, around 30%, a majority of them are stage 4. So that's how.
Okay, so basically you will say if suppose 30% are stage 3, stage 1 and 2, 10%, nearly 60% are
10%.
stage 4.
Yeah.
So 60% are stage 4. Amol?
Majority.
Yeah, so I have never seen a stage 1 lung cancer, to be very frank. Stage 3, yes, almost
No,
10.
you have to find a patient whom you have to give adjuvant therapy, right?
Yeah. So, you know, stage 1 I have not seen. Stage 2, yes, I have given adjuvant chemotherapy to only 2 patients in my last 7 years career in Nagpur.
Yeah, that's the truth. That's the
Yeah.
truth.
Yeah, stage 3, there are a lot many. Like we give NSCT followed by CTRT in such patient. Won't say stage 3, but yes, stage 3 I have seen. Still
Yeah.
2 patients undergoing NSCT followed by
So
CTRT.
stage 4 is constituting how much percentage in your practice? Stage 4.
I would say almost 80%.
80%. So you say that it is 80%, approximately 15% stage 3 and 5% of stage 1,
Sure.
maybe less.
Yeah.
So okay, so Dr. Praveen, what is your how is the practice different from Amol, or you are same like
Same, sir. So,
Akash?
same. So I will say around 80-85% stage 4, 15% stage 3. That also more for the concurrent or the sequential chemo RT. Less than 5% that is comes into rare category, stage 1 or stage 2, sir.
Yeah, I'm finding very difficult.
Last patient I've seen that was in the pre-COVID era, sir. That was a large cell adenocarcinoma, large cell cancer.
So anyway, I think the stage 3 is very difficult to find, even though, you know, Amol has told that there are some here and there patients do come for the new adjuvant chemotherapy, but bulk of our patient, more than 80%, I will say more than 85% are stage 4. Stage 1, like Amol said, you have to literally find, you know, in a year, if you get it, you will be lucky. Otherwise, sometimes you get, sometimes you don't get, like that over there. So now, Amol, in the era of mediastinal staging and EBUS, you know, you go for EBUS or you go for mediastinal staging? That is pathological.
Yeah, definitely we go for EBUS. Mediastinoscope is a bit difficult, you know, it's invasive. So EBUS is a good technology and we just refer for EBUS only.
Yeah, I think now the people who are now recently trained for the EBUS, they are quite smart. Most of the people, they know the nodal stations. Some of the nodal stations are difficult to assess by the EBUS, but somehow I felt the technology is much better. Akash, any other take in your institute? You are the one who is seeing the maximum number of early stage.
So, sir, this is how we do it: PET plus EBUS. So we follow our institutional practice. The practice at our training institute, we follow the same in the private institute.
So I think everyone is going ahead with the pulmonologist, wherever the lung thoracic surgeons are there. Basically, EBUS has come into every city now, and people are not quite well trained. Pulmonologists are quite well trained in that. Now, looking at the management, right? We have 3 questions for all of you. Most of the patient getting 1 is very rare, but still it is further divided into stage 1A and 1B. And 1B is a very delicate area, and you have stage 2 and stage 3. We'll just ask the question to everyone. Akash, stage 1B, surgery alone or surgery followed by chemotherapy?
So, sir, surgery alone, chemotherapy is doubtful. So we use it. So we know more than 4 centimeters now stage 2A in the new classification. So we use it in poorly differentiated tumors, LVI positive. There we
so basically you look at the
criteria is to give adjuvant chemo there, plus minus adjuvant chemo.
Okay, so you look at what is important is that you look at high risk features and take a call separately. Amol?
Yeah, so definitely, rightly said, surgery followed by adjuvant chemotherapy is what I would prefer for a stage 1B patient.
Right.
Yeah.
So only for the high risk patients you will go for it, because most of the trials have been excluding 1B in most of the trials. If even if you see the adjuvant now immunotherapy trial and osimertinib trial, everything is excluding the stage 1B also. They are all going for 2 and above.
Yeah.
Right. Samir, anything different from here? Dr. Samir?
Yes, sir.
Stage 1B. I think you had taken a class for stage 1B for us also, no?
No, sir. I presented a case that.
You
intercepted
presented a
case.
funny case of dual mutation, right? I remember.
Yeah, right, sir. Right. Yeah.
So stage
So, sir,
1B, you go for chemo or no?
More than 4 centimeters. So as per new classification, not, but as per old, yes.
Okay, great. So what you do for stage 2? You go ahead and give chemo plus surgery. Post surgery, you go for chemo.
Sir, if it is more than 4 centimeter, definitely chemo.
Yeah, I think
And
there are some things which every one of us know. Stage 1B is something where we normally look at high risk feature. Based on that, we decide on the adjuvant chemotherapy. We'll come to the other points later on. And stage 2 is similarly managed as like stage 1B. Role of post-op radiation is limited to only certain indications. And stage 3A, basically, I think most of us do go for depending upon, based on the tumor board decision regarding looking at the role of new adjuvant chemotherapy. The role of adjuvant chemotherapy here is not so well defined, and role of post-op radiation is also not so much defined. So these are the trials basically which laid the foundation for chemotherapy. I think all of us know about this, that the benefit is not so great. It is, but still OS advantage of around 8.6. Remember, the trials which have come up in the recently looking at the molecular markers and the immunotherapy, they have not shown any OS benefit. But the previous trial of adjuvant chemotherapy had shown an OS benefit, even though it was hardly 8.6% at 5 years. So looking at the question about, now a patient is referred to you and the patient has got early stage lung cancer and very bad comorbid features, he cannot take chemotherapy. What you will do? Amol?
Early lung cancer, exactly. I would like to know what's the stage of the patient.
Stage 2.
So would definitely go ahead with the CTRT for this patient if he's prohibit surgery, or would like to give him neoadjuvant chemotherapy followed by CTRT.
Post-surgery. This is post-surgery. Post-surgery.
Pardon?
Post-surgery. I will say post-surgery. I'm putting one more condition. The patient has got stage 2 disease post-surgery, but not fit enough for taking chemotherapy.
And so in that case, I know I'm talking about the early stage lung cancer, but still would like to know the molecular status and would be offering him, maybe a oral therapy if at all he's positive for some biomarkers.
Okay. So have you ever in your practice given any patient treatment based on the molecular markers? Early lung cancer?
I wouldn't say early lung cancer, but definitely a curable lung cancer. I would include, stage 3 patient in that, because I'm still giving one gynecologist from Nagpur who underwent NSCLC surgery, and now I'm giving this thing, molecular, basically target therapy as a maintenance. I'm not given her chemotherapy to this because she has positive ALK1. So, yeah.
So even though the data is not so strong for giving adjuvant for ALK positive, any therapy is there or not?
Yeah.
So you have not given that patient, okay, because there is no big role for basically, honestly, a role of adjuvant chemotherapy in ST.
And in fact, neoadjuvant, she didn't respond the way she should respond. So even though she underwent surgery at Mumbai only, but then we opted for, adjuvant targeted therapy rather than going for chemotherapy.
Right. So Dr. Samir, any experience like what Amol told, that some places you decide based on the molecular therapy, molecular markers?
Adjuvant, I haven't treated any patient with any target therapy, but we have data for osimertinib, which is really fascinating. But for ALK, I'm not very sure. We don't have any data, I think, here. So it will be all experimental basis, or we can say it is like compassionate basis rather than any evidence-based medicine.
So apart from this ALK and EGFR, you do an extensive panel testing, or you just go ahead with a limited panel testing, or you don't do at all?
Ideally, you should test only EGFR, sir. If you want to.
What about PDL1? What about PDL1?
PDL1, sir, yes, definitely.
Now data is there for PDL1 also.
Definitely. Yeah, definitely data is for PDL1 positive. More than 10%, I think there is a good benefit.
Okay, so
CPS
what
more
you
than
is,
10.
yeah, it is more than 1%. Honestly, the trial has shown for
But
more than-
greater benefit was in, I think, more than 10, something like.
Yeah, but the
was
approval
like
came from more than 1%, if I'm
But
right.
1 to 10, 1 to 10, I think benefit was not that great. Means
Yeah.
it was more than 10 and then more than 1. So the benefit in 1 to 10% is mainly driven by more than 10.
So you, if given a choice, you will go for only limited testing. You will not go for extensive testing, right?
No, sir. Like BRAF, we have a data. BRAF mutation is positive. The high
No,
risk
no,
of
I'm just
recurrence. That is
asking
the
in
good.
your practice, do you go for BRAF testing?
No, sir. No, practice,
No.
I would
So
not. I would
will
not
you
do
do
it.
will you do the P53 testing also?
No.
Okay.
It
So
won't change the management.
there is a lot of data about P53, how it will affect the chemotherapy, how the BRAF, KRAS basically will affect the chemotherapy. But in your routine practice, in an early lung cancer patient, post chemotherapy or prior to starting chemotherapy, you do NGS or not? That is what I was
No, sir,
asking.
no, not doing. Hardly seeing any early lung cancer patient. But definitely, I'm not that aware because we hardly see any early stage
So
lung
you are
cancer
working in
patient.
a big institute here, NCM में patient तो रहेंगे अभी बहुत सारे.
Sir, बहुत है, but early कोई नहीं आता, sir. Rarely,
कोई
hardly.
नहीं आता.
One
So they,
or in a year or two, one single patient maybe.
okay, and that's the truth here. Whether you are Akash, what is your take on early lung cancer doing a biomarker testing? If at all, which test you do, or you do go for a full extensive NGS?
So, sir, two parts to it. So, based on pure evidence, there only limited markers have a utility. We know that with EGFR, we'll be able to do something with PDL1. But I, in my practice, if I have to send, I send the whole panel. The reason being, sir, we have seen sometimes when these patients relapse, they lose either the blocks, or at that time, sometimes the biopsy is difficult. So we explain the patient that it may not have any utility now, may never have a utility, but because they have become very affordable, we ask them to get the full panel done using a coupon.
Okay, so you go for a panel like 300 genes or 18
no,
genes,
so
12
we get
genes.
This limited panel with the Lal Path lab ke saath, tie-up ke saath, we do this limited panel with
the 12
PDL.
gene panel, the one which we
panel.
normally do it for 9,000, 10,000 rupees, right?
So the reason we do it that way is that we think that logistically it will be easier for us. That is the sole reason.
So it all depends. And remember one thing, most of the mutations do change over a period of time. I think Samir had presented a very good case where, repeating a biopsy makes a lot of significance. Our job should not be that we should do it at the early so that the same panel, same test will remain positive over a period of time. They might change over a period of time. Right, Samir?
Yes, sir. Miss tumor is always a heterogeneous tumor. We can have different clone with different driver mutations. So I think it's wise to do a fresh testing rather than relying on any old tumor tissue.
Depending upon how early the disease comes back, but
Yeah, right.
Yeah.
So that's what I meant. Essentially, we do it earlier so that if suppose later a biopsy is not feasible, ऐसा नहीं हो कि tissue block भी घूम जाए और biopsy भी feasible.
So you always have a liquid biopsy option.
Right. And liquid biopsy is quite good in lung, if you ask me, as compared. Even though EGFR it makes a lot of difference, ALK and ROS are very poor on the liquid biopsy. This point also we need to remember. ALK and ROS are not so great on the liquid biopsy. So anyway, what I think everyone knows is that if we are really trying to see the benefit, right now the data is only to do the EGFR and the PDL1. The rest of the markers also, there is no real data about P53, EGFR, KRAS, and looking at ALK also. There is no ideally a guideline to look for it. It all becomes very clumsy. When somebody has already ordered an extensive NGS and patient has done surgery, stage 2 disease, then you have to give adjuvant chemotherapy. Patient is ALK positive, whether you will add ALK or not. The case which Amol described was more of a case where neoadjuvant chemotherapy patient was not responding. This patient had come to me also, Amol, to take an opinion also. And and later on patient underwent surgery, and the ALK positive based on the ALK positive, we had given the basically anti-ALK therapy over there. So the data is basically more of limited, but yes, it makes you tinker our head more when you send it for extensive testing over there. So I think we will not go too much into the neoadjuvant therapy in early stage. The role is not so much well defined, even though we do go for a certain, we mostly go for cisplatin based, and it's mostly based on the toxicity and everything. But normally the role of neoadjuvant immunotherapy and TKIs, has anyone practiced in their practice in the right now? Amol?
No. New
No.
adjuvant TK or IO, never.
Never. So I think Samir and Dr. Akash.
No, sir, not in my practice.
No, I think no one has gone ahead with the role of any neoadjuvant therapy. Sometimes in a very old patient, early stage case, we do go ahead with the TKI therapy if they are not fit surgically or medically, they are inoperable and they are not fit for any other therapy like radiofrequency ablation or radiation. Very rarely we tend to give it for patients who are like 84, 85, having ILD and other things, we tend to give it sometimes. So these are the randomized phase 3 study looking at the role of neoadjuvant therapy, surgery alone. This I think was already previously put up, will not go too much into it. And these were the trials which were shown to us looking at the emerging role of neoadjuvant immunotherapy long way ahead, before we can really say that this data will ultimately translate into the approval. And but so much success has happened in the role of immunotherapy that we do tend to see that we can use it for the neoadjuvant therapy. Long way ahead, I will say. So adjuvant therapy, basically the routine practice, like stage 1B, stage 2A, 2B, 3A, we go ahead with mostly chemotherapy. Where will you put the role of TKIs, Amol? I think we have a data now.
Yeah, so
you give importance to OS or you go for the DFS?
So in a curative setting, it's always OS, which is more important, I guess.
So OS, the data is not very strong for the ADORA.
Yeah, it's not strong, but if you ask me from this slide, maybe, I would prefer giving adjuvant TKIs probably beyond stage 2B, 2B, 3A. I would rather go for adjuvant therapy as TKI. But yes, it's only after giving adjuvant chemotherapy.
Okay, so you will go for a patient to give first chemotherapy followed by TKI.
I will follow the protocol of adjuvant chemotherapy, and then if at all it's positive, then I would definitely go ahead with the oral TKI.
Akash?
No evidence for that.
I know.
But beyond 2B.
And what about the role of atezolizumab here? One more thing I should put it here.
Well, I mean, I've just used it in metastatic settings, so actually no data. No idea.
Okay, so there is a data. There's a data which Samir was mentioning about it, right, Samir?
Sir, but I would say if driver mutation is positive, always better to do with the target therapy.
No, I'm not talking. Driver mutation is negative. PDL1
if
is
the negative, then you should do a CPS PDL1 score and then you decide according to the report.
Right. So basically, right now the data is there that anyone more than 1%, basically based on the IM power 010 trial, you can ideally, what he said is very right, more than 10% benefit is more, but the approval has come based on the DFS, even though the OS data is not mature, right? And
right.
And this they have given after chemotherapy, remember. So that is what I was telling. The IM power had first given chemotherapy, minimum 4 cycles, then they had given the immunotherapy.
Right.
So Akash, anything will you give a chemotherapy and followed by TKIs in a EGFR mutant patient, or you will directly start on the TKIs? No adjuvant chemotherapy.
Chemotherapy followed by TKI. The reason we say that, even though the benefit of chemotherapy is small, it is a OS benefit. So, and in the ADORA trial, there are both patients, their population who had received chemo, not received chemo. So if the patient is fit, eligible for chemotherapy followed by EGFR TKI.
Right. So any patient you have enrolled for the osimertinib in the last few years?
Sir, so it was a patient who was started for osimertinib from Tata, and we are continuing here. But not our own patient.
Okay, fine. I think it's not so common to
And
have
adjuvant.
patient for 3 years because the cost of 3 years is quite heavy. And recently osimertinib is also, the Bangladeshi variety is also becoming very difficult to get the drug. So there is no OS benefit with the osimertinib, even though the benefit of DFS is quite clear on the scale, which we all know. And this is the data for the ADORA, looking at overall survival, looking at the DFS also. Will not, the important thing to remember is the hazard ratio for the DFS is quite excellent. It's going up to 0.12, 0.16, which is something which we normally don't tend to see it. So Amol, how much you believe in ADORA?
Well, sir, if you can see, the data is really, I mean, it's a good data. So I think we should be considering. I mean, I'm for this ADORA trial. I'm positive for this.
Even I feel what you said is very right. Sometimes the patient turn out to be ROS1 positive, ALK positive. There are no strong evidence, no strong data. But I strongly feel, more than EGFR, these two markers are very strongly, they respond very well to the therapies also, anti-ALK therapy and with the crizotinib and other whatever. So I think I felt that ADORA has a place. Only thing is the cost is a question which we need to think about. Looking at the question of adjuvant osimertinib in stage 1B also, I think we know that 1B is a disease which is quite difficult because no one has done a trial really looking into the role of adjuvant osimertinib. So my question to Dr. Praveen is that will you give the patient any kind of adjuvant osimertinib in early stage like 1B?
Correct, sir. As you shown, sir, because recurrence rate is still in the 1B is high. So after explaining the patient, so I will offer the osimertinib, sir.
No. So will you go for 2 years, 3 years, or because there's no data for any years, or you'll just go for 3 years based on the previous data?
Based on ADORA trials, or whatever. Because
so you will go for 3 years.
Yes, sir.
So any personal experience of giving osimertinib in your patient?
No,
Not
sir.
from 1B, like
No, no, sir.
No.
The best part is now they are coming up with reduced pricing. They have approval for reduced pricing, and maybe the cost of therapy, which was going up to 1.7, is coming down to 1 lakh now.
That is still also high, no?
Still high, but yeah, but still.
And the best and the worst part is, I think, sir, patent is for 2031. So it is a long patent for the AstraZeneca.
So we always have a Bangladeshi.
So it's a long way for the generic to come, sir.
So Amol, you are attending a Astra meeting and talking about Bangladeshi variety.
No, I'm just telling you.
anyway, this is a recorded meeting. Your words are getting recorded over there also.
No, I had a discussion with them, and the main reason I told them is the cost, because it's really difficult if you don't have empaneled patient. See, to be very frank, if you have empanelment, that's okay, but otherwise giving it is quite difficult. And that's the reason they gave me a good news that they are coming, slashing down the price. So that's good.
Yeah. So basically, when I started practice long time back, IRESA was the only thing available in 2009, and they used to give it for 1.5 lakhs. So, but not too many trials were there also, except for the IPAS trial was going on at that time. But after the gefetinib came into place in a generic form, the usability increased a lot.
Yeah.
So I think the usability increases once you start decreasing the cost. Osimertinib is a wonderful drug. I think it has got a lot of place, but the cost is a hindrance for us to use it.
But Astra people have never reduced the cost of IRESA.
Yes.
Yeah,
they never. The last day.
Yeah.
So till it went away.
Yeah.
Totally.
Yeah, that's why it went away, but they never reduced the cost.
Yeah, I think anyway, I think we'll not go too much. We are running short of time. So we know that the adjuvant chemotherapy is the backbone of treating lung cancer, and skipping is very difficult. We, like everyone, was of the opinion that skipping adjuvant chemotherapy is very difficult. That is a place. Adjuvant chemotherapy has got its own place. Adding TKIs and immunotherapy is something which we can do it based on the molecular markers. So this question, I think Samir had already answered. If patient has got a driver mutation in PDL1, mostly we will go for looking at the driver mutation. If patient is EGFR negative and PD-L1 positive, then only we will go for the role of immunotherapy. Based on this trial, IMpower 010, this was a phase 3 global study of ATI versus best supportive care post 4 cycles of chemotherapy, which we were discussing. A patient who had got a PD-L1 more than 1%, basically you can see the DFS improvement at 24 months and 36 months. And the hazard ratio was 0.66 with a very significant p-value. And this was intention to treat population also. So this patient basically showed a very good improvement in the if the PD-L1 status was more than 50%, but the advantage was seen more than 1%, especially in more than 10%. So lastly, a comment from everyone, Dr. Praveen, looking at the lung cancer screening, how commonly in your institute people are doing this lung cancer screening?
We are not doing routinely, sir. So any screening, maybe it is breast or cervical or lung cancer, it is more individualized, not the mass level, sir. So so the patient asks for, then only offer, or the patient especially asks, we discuss, then only offer. Because I think the physician, the chest physician, the MD medicine person, they should be aware that there is something known as low dose CT scan screening.
Low dose, most of the time it is not available also, honestly. They don't do it.
Correct, sir. So although, because even the radiologists also don't know about the low dose CT scan. So that is the hindrance, sir. Then it's still the cost, like Akash mentioned, cost, the interpretation, then the how to follow up, and the how to apply at the mass level. There's so many things are there, sir.
Yeah. So
Even
Samir, yeah, Dr. Praveen.
So if only if somebody asks for, because if there is a high risk patient, and then we offer for the somebody asks, in the family, sir, we have a person who is not having lung cancer, but he's smoker. What we can do? So we then try to offer, but obviously it is difficult to follow up, sir.
Yeah, and second thing is very difficult to tell them how much commonly they have to do it. Whether to do it 6 monthly, 1 yearly, it's a question which is always in the background, especially for the smokers and other thing. So, Dr. Samir, any take on whether we should really look into the guidelines which are mentioned in West and passing on to us? Hello. So, Akash, what is you had given a very nice talk on lung cancer screening, but you do it regularly in your place?
No, sir. So, sir, we not as a part of screening protocol, sir, but what we do is that if a smoker comes, a heavy smoker, we do ask them to get a CT once at least.
Great.
So how we follow them up is like the IPN strategy. If they have a nodule, small nodule, we ask them to follow. So that is how we encourage people.
Basically, it is you have to tell your institute.
Not screening. And national screening program, I firmly believe, I firmly believe that there should be no national screening program for CL lung in our health setup.
So that is what, one thing is that if you see the health packages of most of the places, we are seeing in our institute basically around pickup rate for around breast cancer malignancy because of so much routine screening is around 2%, right? Which they used to come through the health package. Most of the time they come, many places, now the hospitals are going through so much common health package. So the breast cancer, basically the mammography is helping us in finding a newly diagnosed case of nearly 2%. Lung cancer, if you see, basically there is no package per se by any insurance company. So I think it's a long way ahead, but we need to say, and there is nothing called low dose CT scan. It is not so easy, to tell the radiologist to pinpoint. So we believe in normal CT, not for the low dose kind of CT scan. Anyway, thank you everyone. I think it was wonderful discussion. Thank you to all the panelists for actively participating in the panel discussion. Thank you.
Thanks, Dr. Tajinder. Thank you.
Thanks.
Thank you, sir. Thank you so much for the panel discussion and moderating the panel discussion. And thank you so much, panelists, for active discussion. It was a good discussion on managing the early lung cancer patients. I will request all the participants to, if you can please answer these 2 poll questions before we end the meeting. Thank you everyone for joining in. We'll close this meeting. Good night.